Thank you very much, Axel. Ladies and gentlemen, good morning. It's a pleasure to be here, and we all know that there is quite some data available now on embolic protection and on cerebral embolization, and I will try to give you some of my perspectives on the existing data. So recent trials still confirm that there is quite a significant stroke risk, even with newer devices, and also if you move from the high-risk patients to the lower-risk patients. So the stroke rate is still eminent. There is more to it than meets the clinical eye, we know that. So if you do MRI studies before and after a procedure, you will see lesions in up to 77.5% on average. But this means that there is brain injury in all those patients. We're not talking there about clinical stroke, but at least there is brain injury, and that may haunt the patient down the stretch if they have a longer life expectancy. Unfortunately, as we become more experienced, we see a reduction in life-threatening bleeding and major vascular complications, but up to the introduction of embolic protection devices, there was nothing moving in the field of major stroke. We need to zoom in to the pathophysiology of stroke after TAVR, and if we want to tackle stroke with an embolic protection device, it's only reasonable to believe that you will attack strokes in the early hours or the early days after the intervention. I don't believe that embolic protection will affect stroke after 30 days, but definitely within the first 24 to 72 hours. There are 3 randomized trials, MRI-based trials. There is Mistral-C, there is Clean TAVI, and there is Sentinel. Quite a number of patients in aggregate. And if you look at Sentinel, there is a 42% reduction in lesion volume, unfortunately not reaching statistical significance. In Clean TAVI, there was a 50% reduction in new lesion numbers, which was significant. There was also a total reduction of 57% in total mean new lesion volume. And in Mistral-C, we showed a reduction in new lesion numbers, especially in the protected areas. So this is, I think, one of the major findings from the Mistral-C. That was the trial done in the Netherlands. It was a small trial, only 65 patients, but look at this. Any kind of debris was found in 100% of the patients. So every patient that was treated with an embolic, with TAVR, had debris captured in the filters. So what were the challenges with MRI in these TAVR trials? Well, the trials were underpowered because the overall observed lesion volume was lower than expected, but we did not have like a reference on how to do our sample size calculation. There was also quite a variability across transcatheter heart valve types that were used for the primary endpoint. But the question remains, is there a difference across transcatheter heart valves? And most importantly, I think the reason why these studies were underpowered was the dropout rate, the MRI dropout rate of 20% and more throughout those trials. So that left these trials underpowered. So if you combine the trials and do a meta-analysis, then you see a significant reduction in total lesion volume and also a significant reduction in number of new ischemic lesions. So I think it is more than even that. If you combine, again, all the a meta-analysis of all the 3 randomized trials, again, a significant reduction in new brain lesion volume. What about clinical events then? Well, in the Sentinel trial in the US, this was the largest trial, the largest randomized trial using embolic protection device. There was a clear numerical reduction from 8.2% to 4.8% in favor of the protected patients. Unfortunately, the trial was not powered for clinical events, but still this was a strong signal, and it was confirmed and reinforced in the meta-analysis by Giustino, where he saw a significant reduction in clinical stroke rate in favor of the protected patients. This is data from Ulm, and Mieghem already presented this for the first time in a large clinical meeting. And these are quite striking data with a 70% reduction in all stroke at 7 days and all-cause mortality in all stroke at 7 days. So a 70% reduction, which was a significant reduction. So quite impressive. And again, I need to point bring to your attention that we are talking, or if we use embolic protection and we want to see whether it works or not, we need to zoom in on clinical events at an early stage. I don't think we need to wait for 30 days to look at clinical events. I think we have to be earlier. And this is data from the Sentinel trial where they look up to 3 days, and there is a significant reduction even in the Sentinel trial, which was not powered for clinical events, but still there was a significant reduction of 63% in favor of the protected patients. So patient selection, do we need to be selective using embolic protection devices? Well, this is what we do. We put a valve in a degenerated, a transcatheter heart valve in a degenerated valve. We try to use filter protection, then we will catch debris in almost every patient. And this might result even in a reduction in neurocognitive deficit after the procedure. Is this surprising? Well, I don't think so, because we know from the intervention per se, if you do transcranial Doppler measurements, the most embolization will occur during the positioning and the implantation of the device. So whether you use a Sapien device or a core valve device or a direct flow or a Lotus valve or a Symetis, it doesn't matter. You need to position the valve and you need to deploy it, and that's where the embolization occurs. So this is what we face. So we see sick aortic valves, we see sick aortic valves. We will catch debris in all the patients. So, and this is also confirmed in the Sentinel trial. So not only in Mistral C, but also in the Sentinel trial, in 100% of the patients, you will find debris. And this brings me to my conclusion. One of the pathologists in my center, he referred degenerated aortic valves to porcelain. And if you would drop a porcelain glass, how can you predict the size, the number of debris that will occur, or the sizes of the debris? Can you predict it? I cannot predict it. So, and this brings me to my conclusion. I think embolic protection is being used in my center, at least in 85% of the TAVR cases. Why? Because the mechanistic concept is sound and valid. It is relatively easy to use with limited extra radiation and no contrast. APD is safe and will capture debris in all TAVI patients, and the debris size is unpredictable, so why would you not use it? It's almost as wearing a seatbelt. If you're not wearing the seatbelt in traffic, it's not a guarantee that you will end up in a car crash. But if you would crash, you would be happy with a seatbelt, right? Well, we already know that you will have cerebral embolization in all the patients, so why not protect it? And I think this is maybe the novelty in stroke land at TVT. I think we now also have a clinical benefit in favor of embolic protection devices, and I think there are good reasons why the FDA approved the use of EPD or of the Sentinel filter in the United States. Thank you for your attention.